Thank you everyone for joining our meeting today. We are very glad that we are able to host this meeting. The meeting is hosted by Stop TB Partnership, O'Neill Institute for National, Global, and Global Health Law of Georgetown University, and the Communities Delegation of the Global Fund to Fight AIDS, TB, and Malaria. My name is Maureen Murenga. I'm a member of the Communities Delegation to the Global Fund, and this simply is the community that, the delegation that represents communities living with HIV, TB, and malaria. We are the voice of the affected community in the decisions of the Global Fund. I'm also coordinating an amazing organization called TB Women. And this is simply put as women coming together in all our diversity to realize gender transformative and rights-based TB response that will free this world of this old age disease. And though TB hasn't had the attention it deserves from funders, innovators, the global TB response has undergone an amazing transformation in the recent years because we have had these passionate people working in very restrictive environments to actualize the paradigm shifts that we see in the TB response. I remember one time I was telling a story. So many of our friends died of TB, but then we would be told that that is stage 4 of HIV, which is AIDS. But later when we came to know the symptoms of TB, we realized that these guys actually died of a treatable and a curable disease. So today is particularly important because we will discuss the evidence of a right-based, people-centered, gender transformative TB response from an analysis of the community rights and gender TB assessment that has been championed by the Stop TB Partnership. Everyone is welcome. The event is in English, but French language interpretation is also available. So French speakers, there's a button there that shows the globe. You can click on that to get the interpretation. Please feel free to add questions on the chat, and the moderators will direct the questions they see to the panelists throughout the event. I want to give a big thank you to all of us who have made time to come today, and mostly to our panelists, Brian Citro, a human rights lawyer. We have Annie Hannah Sari, a TB survivor. We've got Professor Lawrence Gustin from the O'Neill Institute. Then we got Justin Zionen Taba from the High Court of Malawi. We have Dr. Teresa Kasiva from Global TB Program. We have Eric from Expertise France. Then we have Peter Sands, the Executive Director of Global Fund, and my very able co-facilitator and all-time friend, Luchika. So I'll first of all, without wasting any more time, invite our first speaker, Brian Citro, who is a human rights lawyer, to set the scene and provide context to today's discussion. Brian is the lead author of the recent peer-reviewed publication of Stop TB Communities, Rights and Gender Assessment in 20 countries. And today we'll provide a short overview of the key findings from this analysis. Welcome, Brian.
Thank you so much, Maureen. A very good early morning from Chicago to everyone. It's fantastic to see 60 people here today. So it's an honor to be here and to present the findings from a recent study and article, really a kind of a meta-analysis. So I'm going to share my screen here. And Maureen, is it coming through there?
Yes, it is, Brian.
Okay, thank you. Okay, so as Maureen mentioned, what we're here today to discuss, and the name of the article that I'll briefly outline is how we're building the evidence base for a rights-based, people-centered, gender transformative tuberculosis response. And so I'm just going to kind of give you a brief overview of where this evidence is coming from, and then a high-level kind of review of the results, and also where we published it, and some other pieces of information. And I'll try to do this relatively quickly. So for those of you who don't know, the evidence is coming from the Community Rights and Gender Assessment. And so it's a Stop TB Partnership developed and implemented tool. And the community rights and gender assessment is what we've done a meta-analysis of. And so in essence, Stop TB, excuse me, in close partnership with civil society organizations, community groups, and national TB programs, with support from USAID and the Global Fund, conducted CRG assessments. I'll use the acronym, the Community Rights and Gender Assessment. They were conducted in 20 countries during a 4-year period, 2016 to 2020. And I'll show you the list of those countries in a minute, but it was 4 different regions in 20 countries. So a broad swath of the world was covered. Excuse me. And so what we did is then we mapped out and we analyzed the findings from the 20 assessments. And we did it using 7 dimensions of the International Right to Health framework. And so you can see those there. I'm not going to read through them for the sake of time, but in essence, it covers a broad area of the right to health, but even broader things like liberty and privacy, gender perspective, vulnerable and marginalized groups, et cetera. But these are all components of a legal framework under the right to health at the international level. And so this meta-analysis, as I'll call it, was peer-reviewed and then published in the Harvard Health and Human Rights Journal in December of just a few months ago, December 2021. Okay, so here are the regions, countries, and implementing organizations. You can see 4 regions in Africa, South Asia, Southeast Asia, and then Eastern Europe and Central Asia. And you can see there all the names of the CSOs and community groups and others that were involved in actually doing the research themselves. Okay, so what did we find? So this is a colorful graphic that what it shows you here is out of the 20 countries, whenever we identified an issue in 10 or more of the countries, we've put it here on this graphic. So what this graphic really shows you are the most common or the most frequent human rights problems, or at least concerns under the right to health, that occurred in the 20 countries where the CRG assessment was conducted. And so I'm going to touch on a few of them on the next slide, but I'll just let you take a look and I'll kind of explain this a little more. So I know I often just look at these things and don't understand them until I get to read them. So if you look to your, what should be your right of the screen, the kind of bluish green color, those are issues that we identified under the availability, accessibility, acceptability, and quality of health services, facilities, and goods. So just by example, you can see that in 11 countries, the assessment found that people with TB have a problem with the standard TB treatment. So there are quality concerns with the standard treatment, including that it's directly observed therapy, that there are side effects, that it's too long. If you look at the orange, these are discrimination and equal treatment issues. And you'll see there that, for example, in the bottom right-hand corner, in 11 countries, the findings demonstrated that people affected by TB experience discrimination in their families and in their communities. And then as you go through, you'll see concerns around gender, freedoms, participation there in the light blue, remedies and accountability, and then vulnerable and marginalized groups. And so I'm going to now just touch on maybe I think it's about 10 of the kind of top results that we found. So the first, and this is going by the most common or the most frequent. So in 90% of the countries, 18, people affected by TB experienced stigmatizing and discriminatory treatment in healthcare. So both when they were seeking or getting TB care, but also just in primary healthcare settings as a person affected by TB. 75% of the countries, we found that people affected by TB are discriminated against in employment. So it affects their livelihood. So despite this, 19 of the countries, 95%, do not explicitly prohibit TB discrimination in law. So it is not illegal to discriminate based on TB. In 18 countries, or 90%, there's a lack of recognition or protection for privacy and confidentiality in law, policy, or practice. And that leads to breaches of confidentiality and privacy that, among other things, actually deter people from using health services in the first place or from continuing treatment. In 80% of the countries, there are legal, policy, and programmatic gaps for TB key and vulnerable populations. In 13 countries, 65% of the assessments reported that patriarchal norms negatively impact women's access to TB services, also increase their vulnerability to TB infection and disease. And lastly, in 60% of the countries in the meta-analysis, women affected by TB experience more frequent or intense stigma and discrimination than men, sometimes leading to abuse, gender-based violence, or abandonment. And so with that, I'll stop. And again, thank Stop TB Partnership for having me as a part of this important discussion.
Thank you very much. And I think it's a great honor and pleasure to be here, all of us. And I want to thank you very much, Brian, for the engagement and the work throughout this process. And to be honest, looking at the findings, it is heartbreaking. But as Maureen said, I am actually thrilled or maybe happy on the fact that we are at this moment now in TB, that we are able to have the evidence to articulate this and to justify and to show that it's a reality, because we used to say this kind of things, but it was very difficult to sustain a good dialogue and an investment without having the information and the data. So thank you so much, Brian. And I want to go to our friend, Ani. I want to thank very much Ani for being with us today from Indonesia. Ani is not only a TB survivor, she is the executive director of Rekat Indonesia. And Ani, I think you experienced some of the things that were mentioned there. I think you went through a lot as a TB survivor. So I want you to reflect a little bit on that as a TB survivor, but also on the findings as a co-author of this analysis. But also if you can touch briefly on what you want to see happening next. Thank you so much.
Thank you so much for the introduction, Lucica. And yes, I'm along with Maxim and also Olia. I was one of the 3 TB survivors who joined Brian and the team in authoring this analysis. My TB journey to find medication began in 2011, and I changed from one specialist to another. Some said that I have allergic, and some suggested that I have to travel abroad for diagnosis and treatment. And some suggested that I have TB, but was after that I prescribed incorrect medication doses. So that moment my health continued to decline, and I was collecting blood eventually. And after that I seen another doctor and was diagnosed with MDR-TB. Shortly after my diagnosis, I'm pregnant, and I was getting injection every day that moment, and my side effects were more extreme.
Annie, I think you muted.
You muted yourself, yeah.
Sorry. That moment, my health continued to decline, and I was catching blood, eventually seeing another doctor, and that moment I was diagnosed with the MDR-TB. Shortly after my diagnosis, I'm pregnant, and that moment still get injection every day, and my side effects were more extreme. And that moment, when I have to giving birth, it was the beginning of my experience with TB and stigma. So I was placed in a glass isolation room, and that moment my privacy and confidentiality was ignored. I was yelled and ashamed that was on display. I have never been more embarrassed, and despite of being a mother of a newborn, I have never felt more alone. I was separated from my child for 8 days in the hospital, and my child have to drink milk with a bottle prop in a box. So he have to drink with her head, his right side. And when he was discharged from the hospital, his right head was flat and not round like the general head of other children. And at that time, I swore that I would never again give birth at that hospital. My experience of TB was and will be connected with all my experience as a woman. And while I successfully completed my treatment in August 2013, I was again diagnosed with TB along with my child in 2015. This time it was TB drug sensitive, but again, my experience was one of where the gender and TB intersects. I had to leave work earlier, took care of my child and my brother and myself as well, all recover. And my testimony here is my life and the life of my family, my life in Indonesia, but also my family of TB survivor all around the world. To the process of mapping and also analyzing this GRK assessment as we did for this article, I know that I'm not alone as a human rights barrier to TB service and are part the life of millions of the people every year. Now we have evidence and we know more than we have known about the experience of the human right and the gender-related barrier to TB. Nobody can ever say that the human right and gender are not the central of the TB response. And we must know that invest in this aspect of TB response more than ever before. Access to information, quality TB drug, freedom from stigma and discrimination, and making sure that TB services are nuanced to different people experience, including in terms of the gender and the key and vulnerable population status is essential if you want to end this epidemic. A significant component of this building a community voice and movement for the demand generation, for accountability and for participation. My organization has been very fortunate to be supported by the Challenge Facility for Civil Society Grant Mechanism. We must ensure that TB survivor network in all countries receive the support that we have if we are to address the human rights and gender-related barrier to TB service. Find the missing million and the epidemic, and that the national program include intervention, funding and accountability indicator in support of this. I call on the Global Fund to scale up investment in TB and human rights in the country grants in the upcoming new funding model 4. I call on the Global Fund to also dedicate more funding to TB and human rights through the catalytic investment. With this new evidence, the next GRG must have an enhanced focus on TB. I also call on the donor government, including friends who are joining us today, to scale up their investment directly into building TB community system and the promotion and protection of human rights through the USAID and the Global Fund supported Challenge Facility for Civil Society. And as my friend in the Francophone Africa Network Draft TB have recently careful. Over to you, Lucica.
Thank you very much, Annie, for that moving story, and thank you for the courage to tell your story to the world. And we have heard from her, a person living with, or a person who has TB should not lose their dignity. People need to be treated with dignity and with respect, and such violations, if they continue, we may not defeat TB as an epidemic, because we need to address those barriers. And the colleagues from Global Fund, you have had Annie, we need more resources. If these paradigm shifts have to become actuality or have to be actualized, then we need more resources for this. So thank you very much, Annie. And now to Professor Lawrence Boston from O'Neill Institute of National and Global Health Law, Georgetown University. The question to Professor is, we currently face a pandemic that has disrupted and is still disrupting access to care, resulting in fewer cases of TB detected, fewer people receiving care, and more deaths, as well as critical threat of multi-drug resistant TB overtaking our inadequately funded pipeline for the new medications. In what ways will increasing our investment in law and policy environments that prioritize community leadership and human rights make the global response to TB more resilient to health emergencies and stem the rise of antimicrobial resistance, TB?
Well, thank you very much. I think really Annie's story said it all about the importance of a human rights and a dignified and equitable approach to tuberculosis. Nothing could be more important than her voice and the voice of those affected by tuberculosis. I want to begin by really congratulating the group that's done this research, because what they found is not surprising to any of us who've been involved in tuberculosis for so many years, but it documented it in such a careful and important way that I hope it's going to wake up the world's attention, not just from the Global Fund and donors, but from governments and civil society and community organizations. I want to kind of tell a little bit of a story, if I may, among a number of diseases. Right now, the world is, so focused on COVID-19, and probably one of the modern pandemics, modern compared to tuberculosis, is HIV/AIDS. So I want to weave a little story between COVID, AIDS, and tuberculosis, and make the point that actually they do have all interconnections. So let's start with tuberculosis. I mean, it's probably, or at least among the most ancient diseases. And I think it's typical that the very first finding of tuberculosis was 9,000 years ago. And it already gave us a hint about gender, because it was a mother and a child that were buried in the Middle East. And ever since then, tuberculosis has had deep implications for justice, discrimination, stigma, lack of availability of services, and lack of effective services. If you think of COVID-19, we've really only experienced SARS-CoV-2 as a world community for about 2 years, or a little over 2 years. Already we have over a dozen vaccines, 2 new messenger RNA technology vaccines. We have therapeutics like the Pfizer antiviral medication that can keep you out of hospital. And yet, for TB, we're still struggling. We're struggling. We've got a diagnostic skin test that has essentially been unchanged for about 90 years. We have treatments, but really significant problems of antimicrobial resistance in the form of resistant tuberculosis and extremely resistant tuberculosis. And so, investing is really important. And now I want to go back to AIDS and try to kind of wrap a lot of this up. Because, I kind of began my career in the AIDS pandemic. I was, right at CDC at the time when they first reported the first AIDS cases. And AIDS also was and still is actually a disease like tuberculosis of stigma, discrimination, gender. All of the human rights elements were deep. But I believe that AIDS changed the world. And it changed the world in this way. It showed us that the only fundamental change, literally the only fundamental change, is one that is based upon deep social mobilization of persons affected by the disease leading and speaking out in really graphic and powerful ways. And AIDS, the AIDS community, led by the Treatment Action Campaign in South Africa and ACT UP in the United States and elsewhere, have really transformed the way we do this. And what this report does is it shows us that voices from the communities, from civil society, that focus on the key issues that really matter: stigma, discrimination, dignity, availability of services, literally the entire panoply of human rights concerns and the right to health, like the accessibility and equality and quality of services, stigma, discrimination, privacy, freedoms, vulnerable populations, and also that there needs to be transparency and accountability through the rule of law with legal remedies. So this paper provides more proof of the importance of empowering civil society and community groups to shape, lead, implement the global health research agenda, to sustain and expand this research, and to invest in research and leadership capacities that community, civil society organizations, and academic institutions need to partner with. And when we do that kind of advocacy, scholarship, and research, we need to focus on the real issues, which are human rights barriers, and how we can operationalize effective interventions. Tuberculosis, I often would tell my students that, like many diseases, you wouldn't think that it would be so discriminatory. After all, it's just a pathogen, nothing more. And in fact, in high-income countries at the turn of the 19th to 20th century, it was called the social leveler, and people of high means used to go out to the countryside. But now it's really impacted among the poorest racial minorities, women, particularly in higher income countries, but it's true in all countries, I think. So TB is a disease of marginalized populations, and people from those populations in particular need to be part of the solution, and they need to be able to live and get treated with dignity and without fear of stigma, discrimination, criminalization, or coercion. And now, circling back to the COVID-19 pandemic, it's actually made an already bad situation with tuberculosis worse, because we've been able to detect fewer cases of TB. Fewer people have received, quality care and treatment. There have been more deaths. And while we've seen the relative, but only relatively greater resilience of HIV during this crisis with treatment, this reflects in part how more substantial progress toward respecting and protecting the rights of those living with HIV have come. And I've talked about how AIDS did change the world. And so the task ahead of us is enormous. It's one to make sure that we've got ever better treatments, more access to high quality treatments, that they're done in a human rights friendly way, in ways that protect people's dignity and rights, and also to contribute very much to one existential threat that we rarely hear about, but we need to, which is antimicrobial resistance. And TB is among the most challenging in relation to that. And at the same time, we need to strengthen the case for action and create accountability for progress. We need to seize an evidence base that's been established by the Stop TB Partnership through their community and rights gender assessments, as well as other programs such as the Global Fund's Breaking Down Barriers initiative, to further invest in and expand the evidence base for community and rights-based responses to tuberculosis. So my hat goes off to you all. My heart goes to you, and we really need to focus so strongly on the human right to health in the fight in TB. Thank you, and over to you.
Thank you so much, Professor. It's an honor to have you with us and also to hear your reflections. And I really hope we did some great work with O'Neill Institute in the past, and I hope we will continue as we embark into an important but not easy road ahead, as you said. And now is my big honor as well and pleasure to introduce Justice Zion Ntaba from the High Court of Malawi. I'm very honored to know you, Justice. I know of your huge and important experience that you have. I hope you can hear me. I know we tested the sound and the video before, and I hope you are still with us. Justice, if you can tell us a little about the important role that the lawyers, lawmakers, and the judiciaries play in strengthening the human rights-based health laws and policies. I don't know, James, if Justice is still with us. I think she was trying to unmute or open her camera, and then it disappeared because I saw that movement when I was starting speaking.
I think she's just joined with us again.
Okay.
But I think her audio might have a challenge, Luchika, so maybe we can move to the next speaker while we work on Justice Ntaba's audio.
So yes, so then maybe Maureen, you introduce Teresa, Dr. Teresa Kasaiva, and we come back to Justice.
Yes, I will. Thank you, Luchika. So I want to invite Dr. Teresa Kasaiva from the World Health Organization to reflect on the following. In light of this further human rights and TB evidence, what steps can WHO at global and country level take to further scale up and further prioritize overcoming human rights barriers to TB services, possibly including the WHO technical guidance, activities, and processes? Yeah.
Thank you very much, Maureen. Good morning, good afternoon, dear colleagues and friends. It's a great honor for me to join this important event, and I can see it's very inspiring. The audience is growing, close to 100 participants. Of course, it's extremely important topic. We are bringing nowadays within TB community and beyond, sharing our concerns about huge challenges and gaps in financing, lack of innovations, and deprioritization, and sometimes even neglection of TB-specific issues, not addressing them, undermining human rights of people suffering with TB and their households, and in general, huge stigma and discrimination. And if you will ask me to identify the key source of all our problems, main reason, it's of course, I would like to refer, and as we all here in agreement, that the human rights and huge inequalities and stigma are our biggest issues, and all the rest, then lack of prioritization, lack of funding, all the rest is built on it and based on it. And that's why it's crystal clear that it should be addressed first, and we are here all unanimous. I would like to congratulate you with this important study, research, and these assessments once again brings us evidence. It's not about some bringing general issues that human rights are important. These kind of assessments prove that we can bring evidence which shows where are our biggest challenges. And of course, I would like to refer to our global TB report, to the data we are monitoring now on monthly basis, not on annual, much more frequently. And it clearly shows these huge gaps and not addressed needs and deprioritization of human rights. I will not go in depth, you all know very well what is our current status. We severely pushed back in terms of progress towards our targets, and we have big drops in TB notification, in access to essential TB services. But just a few numbers highlighting this problem. According to the last year report, 4.8 million people were diagnosed with pulmonary TB, and out of them, only 59% were bacteriologically confirmed, and only 33% were diagnosed with use of WHO-recommended rapid molecular diagnostic tests. What it means, these are not just numbers about the access to diagnostics. It clearly shows that in the 21st century, despite of having better tools for diagnostics, we are still diagnosing many people with TB just based on the symptoms. It's absolutely not appropriate. Can you imagine that you are diagnosing cancer or HIV based on symptoms when you have better tools? And it shows, again, the huge inequalities. Why, if you have access to better diagnosis and treatment, why people should not have them? And I would like also to bring another example. For the past 5 years, we've dramatically reviewed all our internal processes and optimized them in terms of guidelines development. And now we have regular updates annually, sometimes even more frequently, and we can propose much better options, 2-3 times shorter treatment, fully oral treatment, much more effective treatment, and still treatment coverage in the same time is only 59%. It means that almost half of the people who need treatment have simply no access to this treatment. And we have a lot of different options. Yes, we don't have a point-of-care tests. We don't have a new effective vaccines. But when we are looking at the progress towards our global targets, it shows not only our failure that we are not reaching these targets, it shows that there is a group of countries who have enough financing, they have enough investments, and they are reaching our targets. They are reaching NTB strategy milestone targets, even high TB burden countries. This is the question of prioritization, sufficient investments, addressing human rights. This is all about human rights. And if you're considering rights of people, the poorest, the most vulnerable, it clearly shows that you are taking TB seriously as it's appropriate. It's kind of another myth that we don't have tools effectively address TB. We have tools, and if we will use them, we can dramatically improve the situation, even in the absence of the effective vaccines and point-of-care tests. So we are looking for the data, and we're always asking, oh, we need better data, more regular. Now we have more regular data. We have data from this assessment. The question is how we're using this data, how we are addressing. If everything is remained the same, so sorry, these requests are just excuses for not taking actions. We know very well, I also just would like to bring to your attention another numbers, that number of people due to COVID facing social economic problems is growing, and we already predicted if these issues like poverty and undernutrition will not be addressed as soon as possible, we can see further dramatic growth of TB. And it's not something additional, it's absolutely essential to provide nutrition, food support, and addressing needs of the most vulnerable. All the evidence is there. no excuses, and just we should take an actions. And I'm extremely happy that we are working with the partners closer, much closer than ever before. We are unanimous in our messaging, but we should go beyond just TB community, and that's why we are trying to use every opportunity. So this day, which is not World TB Day, World Women Day, World Men Day, Day of People with Disabilities, just to share our messages why TB, people with TB should be prioritized. And we will have then UN high-level meeting in 2023. It will be great and absolutely essential to put spotlight on TB and to reaffirm these commitments. But it's not only about the commitments, it's about the follow-up actions, and every stakeholder, not only member states, should be accountable on the commitments made. These targets, very ambitious, on funding TB research, funding TB progress, remain unaddressed, and we can see even drop in the TB financing. So that's why, once again, just would like to say thank you very much. And this is great work, and we are fully on your side. And I must say that TB should be an indicator of social justice, indicating every member states and in every community. So with this, thank you very much. We'll be happy to stay with you and to respond to the questions if you have any. Over.
Thank you, Teresa. And this was very to the point and very strong coming from WHO, and it's good that we have this amazing partnership. Without further ado, I would like to pass the floor to Justice Ntaba. I know you are with us. Justice, good to see you. You are an amazing. I'm happy to have the High Court of Malawi with us, and on a personal level, I'm honored to know you and to thank you so much for all the fights that you do there in Malawi. And I think you deserve to be known globally for all the work that you are doing. And Justice, please, can you go and from your position and experience in the law and in the judiciary, can you tell us a little bit about the important role that the lawyers, lawmakers, judiciaries play in strengthening the human rights-based public health laws and policies? Thank you.
Thank you so much. Apologies for the glitch in the technology. Greetings from the woman of Africa, although right now it's really wet, but we're looking forward to the sun in the next few months. I think, let me start from this point of view. The fact remains that each and every player and each and every issue that you've highlighted plays a very strategic role. You talk about lawyers, you talk about the law itself, you talk about the judiciary, and you talk about lawmakers. One cannot talk about those parameters of people or issues without recognizing the intersectionality that these people and issues play in each other's lives. And I think it is more important, especially when we talk about human rights as they relate to the health, because of the interdependence and interrelatedness of human rights. Whether you talk about the right to health, you talk about the right to development, they correlate if one's health is not in the best way, but also not only that, if human rights violations within the health sector are not addressed. So it is important, I think, ultimately at the end of the day, for all of us to recognize that we need to have laws that actually are not inherently vague for people to be able to use. We need to have laws that actually promote and protect human rights. And we also need to have laws available, because the other problem is you might say, oh no, the Constitution says this, but if there's no law that actually gives to effect some of these issues that come into play, for instance, in the health sector, the non-discrimination aspect, how does it really relate when you're discriminated? In public health, for instance, where can you keep a person who's got multi-resistant TB, as opposed to, because some of our laws continue to say, look, you must keep them in a prison setting, or if they've run away, they should be incarcerated because they continue to be a public risk. So the issue of the availability of the law is also very important and very strategic. Now, lawyers play, I think, a very fundamental part in terms of human rights. And if they're not themselves, and judiciaries and lawmakers, and especially even implementers, alive to the issues, but also responsive to the issues, then there will be no change in the system where there's been violations. For instance, we are so thankful that we have lawyers in Malawi who take up strategic impact litigation in such cases. It's very important for that to happen, because no law can change if nobody has brought in a case or has taken the issues before a court of law. Because sometimes, despite the fact that as courts, we can initiate certain issues, but it is always very difficult for us to start the process. We need somebody to move the court. And when we take that into account, you look at the fact that most of the issues that I've talked about in terms of health rights or human rights issues in the health sector, a lot of people argue, oh, they're unjustifiable or they're unjusticiable. We have been lucky as in Malawi that most of our courts have said there is nothing that in our constitution and in terms of the Bill of Rights where somebody can say they cannot come before the courts and try to address those rights that have been violated. And I think it is on that basis that we've had very significant things come to pass and come to change. And I think that has also moved our lawmakers to start thinking about how they do law. Does the law itself address the issues that they need to address? If the law was to be passed, will it be challenged in parliament? You hear the debates that happen in our parliament. They start saying, but this might not be legal because of A, B, C, and D. And somebody could challenge us in court for this. And I think that's very significant. I will give a perfect example of how this came about. For instance, the HIV and AIDS bill that we were trying to pass a couple of years back has very interesting provisions that if they had been passed were going to be problematic. But lawyers, judges, lawmakers, civil society all came together for one strategic meeting to actually look at and to get advice from each sector of society, including people living with TB, as to what it means if this particular provision will pass, and people living with HIV as to what it means if this particular provision will pass. And I was glad with that particular process, that strategic and collaborative process brought about the fact that that law, those particular problematic provisions, which if they had come before a court would have been declared inherently bad, were now changed. But that only comes into play if we all, and I mean all, justice players, whether you talk about lawyers, judges, lawmakers, law enforcers, are actually very much aware of what the human rights aspect of those issues are. Because if they don't, then we lose the plot altogether. The legislature will not pass laws that actually promote and protect human rights, and neither will they hold accountable the other aspects, the other two arms of government, because it is hoped that in the checks and balances issues, the legislature will hold us as judiciaries accountable, and they will also hold the executive, who actually have a lot of the human rights violations coming from their system. If they don't do that, they will not be alive. And in terms of us as judiciaries, I think one of the biggest things we've seen is that if we get the cases before us to understand the inequality issues, to understand the discriminatory issues, to understand what it means for the violation for that person. Because I think most times when a violation comes, a lot of people just see the person themselves, the one who's been violated. But behind them, they've got so many other issues, so many other people that get affected by the fact that they have been let go out of work. They are not getting the right treatment. The safety of their families at risk. And those are things that I think we need to look at. So I think as judiciaries, one of the things that we continuously and must continuously do is be alive to the issues that are before us, but also promote the rule of law by ensuring that the issues are upheld. And I think we also need to raise awareness, because I think most times people think of judiciaries as when they come to court, but the legal awareness that comes from cases that we do as judiciaries has such a big impact. So it's something that I think as we continue on with the discussion about health rights, especially with the human rights context, we need to ensure that the judiciaries are part of that debate and dialogue and are present in decision making, especially when it comes to legislation and policy. That's what I would say. Over and out.
Your Honor. A pleasure to listen to you. I think we all benefit from your presence, and I really hope that we will be able to have more interactions and more panels together and more. I think it's not about having a panel, it's about sharing this kind of thinking and going forward. So I will have the pleasure to introduce the next speaker, and then my co-chair Maureen will take over, but I'm really happy to have here with us Eric, a very close friend of several of us, of mine, with a huge heart. Eric comes from l'Initiative France. And Eric, your experience and your interaction and your knowledge of the field makes you perfect to reflect a bit on the fact that during the COVID-19, many national responses were actually constructed a lot through the work of TB community-led initiatives, demonstrating the importance of investments in TB. You know, I know a few cases in which literally communities, health workers for MDR-TB stepped in and did COVID in both India, in PNG, and in few other places. So what can be done to really close, to look at the funding gap that we have and see how we can increase investments in TB communities, but as well as Teresa pointed out, the dramatic lack of resources in TB, and you know that very well, and now we come with the need for huge interventions in the rights of people. And so what would be your reflections around this? And thank you so much, Eric, for agreeing to be with us. Thank you.
Thank you very much. Sorry, thank you very much, Lucica. And once again, thank you for having me in this wonderful panel. I would like to start that with we are always in need for, you know, better technologies, better treatments, better diagnostics, better vaccines. And about vaccine, I would like to mention that next week the Global TB Forum will take place in Toulouse, in the south of France. We have no doubt about that, but I'm equally convinced that we need a paradigm shift in our joint approach to tackle TB. And for that, of course, we need not only to sustain the current investment in TB in a context of another huge pandemic, but there's also a need for bigger investment. I mean, more and more money fueling the TB world. And first, I would like to mention the huge, the urgent need to support community, civil society organizations, and more broadly, all community-based intervention. I believe that a more community-centered approach would most certainly boost population sensitization, raising awareness, access to diagnostic, and then access to treatment. Community-based organizations, they have been extremely pragmatic in supporting patients dealing with several months of treatment without systematically using a dodge approach that could sometimes be too intrusive. The empowerment of people with TB is possible, we know that, it's feasible, we know that, and it's a massive contribution to the success of TB treatment. Then I'd like to explain once again that l'initiative, the set-aside facility set up by France, implemented by Expertise France with a fraction of the French contribution to the Global Fund, is increasing its support to the whole TB community, including to CSOs. And I've seen the list of community-based organization you showed us at the beginning of this webinar. Many CSOs that we are already supporting. However, we consider it a too small portfolio so far, and we are seeking for more applications to our calls for projects. In parallel, we are already very happy to be able to assist CSOs and national TB programs in their efforts to reach out to the most vulnerable, the most discriminated people, like prisoners. And I was in Burkina Faso 2 weeks ago, and I'm very happy to see that we are working together with the National TB Program in Burkina Faso to reach out to prisoners with TB more easily. And I think a similar effort should be also made to reach out to children with TB, of course. There's no reason for leaving children with TB behind. My message is very simple. Use us. Use the initiative to increase the opportunity to take some risks that other fund providers are less likely to take. Use the initiative for innovations and for paradigm shifts. And in conclusion, it's not only a question of funding, Lucica, you know that very well. It's also a question of human rights, the right to have access to the better treatment, to the better diagnostic and vaccines, but also the right to have access to services without being discriminated against in care facilities, in communities, in families, in working places. The right-based approach should be clearly translated in national strategic plans. And we have a wonderful opportunity because most of the national strategic plans are going to be reviewed or updated in the coming months before the global funding request. So let's do it. So activities related to the promotion of rights could be eventually funded. And I like to insist on the need to have in these huge efforts on rights and empowerment, the need to have more programs dedicated to women at risk for TB and women with TB, because for too long, and I've seen that during the last 25 years, the TB world has been a male world, and it's not acceptable anymore. And I'm very happy to say that, I mean, because I strongly believe that we need more female leadership, female scientists working on TB. Then I'd like to add to conclude that the challenges ahead of us are also related to our appetite for risk. How much risk are we ready to take to find out new ways to tackle TB and then to contribute to the goal of elimination? For me, this is a very important question. We have to put this discussion, this question on risk on the table, and with that, I think we will be ready to contribute to the goal of elimination. Be sure that France is committed to supporting all these efforts. It's totally aligned with our global health strategy. And once again, I mean, TB must not win. Thank you.
Thank you very much, Eric. That was really powerful. We must have a risk appetite that will enable us tackle and find innovative and new ways of responding to TB. So now I'll invite the Global Fund Executive Director, Peter Sands. Welcome.
Rights and gender issues in the context of TB. I congratulate you and your team on publishing this important article in the Health and Human Rights Journal. I've read it with great interest, and I'm proud that the Global Fund, as a donor committed to human rights and gender equity in health services, has actually done quite a lot already, working alongside partners to respond to the TB-related human rights concerns noted in the article. And this commitment will continue and be further strengthened as part of our next strategy, fighting pandemics and building a healthier and more equitable world. The Global Fund has come a long way on investing in TB-related human rights programs, from a negligible 0.08% of Global Fund TB grants in NFM1 to attaining our 2% KPI target in NFM3, the current funding round. This represents over $34.5 million invested in programs that address the kinds of barriers identified in the CRG and other assessments. This has been a journey. In 2016, we refined our definition and understanding of human rights programs in the context of TB. With the support of technical partners, community representatives, other TB experts, as well as human rights experts, we developed 10 key human rights programs in TB, as described in our technical brief, Tuberculosis, Gender, and Human Rights. In 2017, we launched the Breaking Down Barriers, or BDB initiative, in 20 countries to develop and sustain comprehensive programs to reduce human rights related barriers to HIV and TB services. To kickstart the BDB initiative, researchers carried out baseline assessments of human rights related barriers to HIV services in all 20 countries and to TB services in 13 of these countries. The multi-stakeholder meetings conducted after these assessments provided a unique opportunity for communities, governments, civil society organizations, technical partners, and other key donors to come together to discuss the assessment outcomes and to develop country-owned national strategic plans for scaling up programs to address the barriers identified in TB and HIV. Human rights matching funds from the Global Fund, initially only available for HIV, were made cross-cutting in this funding round and have been used to incentivize countries to increase investment in programs to address human rights and gender-related barriers to TB services. Midterm assessments of breaking down barriers of BDB conducted in 2020 and 2021 documented remarkable progress in rights-centered TB programming in many countries, including TB program areas previously neglected and in community-led and based human rights responses. Just to highlight a few examples. In Ghana, paralegals recruited from among TB survivors manage cases of TB-related discrimination in employment, evictions, confidentiality of TB status, and other issues. We're working with the TB Voices Network Ghana, a network advocating for legal protection against firing people while they undergo treatment for TB. In Mozambique, community TB champions are trained to monitor human rights violations in the context of TB and provide access to legal services when needed. In Kyrgyzstan, the NGO TB People conducts regular monitoring of TB services, reporting results to a web-based platform. Activity in this area led the Ministry of Health to create trust councils at TB centers to receive and act on the results of community-led monitoring to improve TB services. In Sierra Leone, we're working with CISMAT, a TB community organization, to conduct a TB stigma assessment. More recently, many of these programs were adapted to address COVID-19 related human rights barriers for people with TB. In Ghana, for example, COVID-19 related stigma and fears were widespread earlier in the pandemic. People with TB who had a cough feared being misidentified as having COVID and thus hesitated to use health facilities. The NGO TB Voice Network produced a video to raise awareness of the need for people with symptoms of either disease to seek care without being stigmatized, eventually reaching about 100,000 people. While we have made a lot of progress, we also know we have a long way to go. Building on the lessons learned from the initiatives and interventions I've just described, we're committed to further scaling up support to countries and to working with communities and partners such as Stop TB Partnership and WHO to ensure an evidence-based and comprehensive human rights response is an integral part of national TB responses. Among the ideas currently being discussed are a human rights matching fund specifically for programs to reduce human rights related barriers to TB in the highest priority countries. I look forward to your input on the ongoing consultations on this and other proposals. Thank you.
Thank you very much. That was a really encouraging speech from the Executive Director of the Global Fund. And we are also looking forward to continued discussions on how we can have more resources to respond to human rights barriers. We have run out of time, and I was wondering if among the panelists, there's someone who wants to say to give additional comments. I can see from chat we didn't have a lot of questions. So just wondering if someone wants to give additional comments before we close the meeting. Well, I haven't seen any. So yeah, so today we have learned an amazing, we have had a very important discussion. Thank God we've had it before 2030. It was long overdue, but we are still on time to do amazing other things, to respond to the barriers. So we have learned that we cannot medicalize our way out of TB. We have to remove TB from the laboratories and health facilities. And those are very important, but also address the social response, address the gender inequality, address stigma and other human-related barriers to access. And what Eric said that really caught me is that we need to also have a risk appetite that will ensure we leave no one behind, that will ensure we take risks that will help us find new ways of addressing TB, including bringing women on board. Women are amazing and they bring a lot of changes. Men too. So I want to thank Stop TB Partnership, O'Neill Institute, and the community's delegation to the Global Fund Board for hosting this meeting. I want to thank all the speakers and my co-facilitator, Luchika, and all of you who have joined and stayed on the meeting until now. Thank you very much and have a wonderful the rest of your day. Thank you. Bye.
Thank you very much.
Thank you. Bye-bye.
Bye, everybody.
Thank you.
Good day.
Thanks and bye.